we see a lot of crazy foreign bodies that end up in, rear ends, front ends, vaginas, et cetera. And the stories are always entertaining.
Before we dive in, it's important to remember that the information we provide is for informational purposes only. Every situation is unique, and decisions regarding your health or legal matters should be made after consulting with your own doctor or lawyer. Our aim is to inform and empower, but personal circumstances require personalized advice. Hi, welcome to another edition of Justice in Scrubs. I'm attorney Richard Hastings, and unfortunately, I will not be joined by our co-host, Dr. Jeff Michaelis, who is suffering from the effects of COVID. Today, we are joined by a very special guest who's going to present us with some very interesting and insightful information. He is Brian McCambly, and he is a PA, or was a PA, at the Danbury Hospital Emergency Room, and we're going to talk about your journey.
Yeah, absolutely. I'm happy to be here. Thanks for having me.
Thank you for coming. So why don't you start and tell us about your educational background and how you became a PA?
So I think I've always wanted to do healthcare from years of volunteering at the hospital when I was younger, and junior high and high school. I was fortunate enough to work with a group in the emergency room on Long Island where I grew up, a bunch of PAs, and that kind of sold me on the career. So I went to undergraduate at a small university in Pennsylvania where I did my PA training as well, and embarked on a career in emergency medicine for the last 26 years. Up until recently, where I'm transitioning more to the sort of an urgent care role. But my entire career has been at Danbury Hospital in the ER since I graduated school back in 1999.
And emergency medicine is different from every other type of medicine in what ways?
So I think it's the acute nature of people being acutely sick. You are there 24/7. There's nothing that we turn people away for. We see all comers, pediatrics through geriatrics. Insurance, no insurance, none of those questions are asked or matter when we see patients that walk through our door. So I think we are the safety net of healthcare in the United States.
And you see anyone that wanders in from, say, a flu to, they're near death and they end up passing away.
Yeah, I mean, it's a very broad spectrum of disease process for, the bread and butter, what we would consider private practice, family medicine kind of complaints, sore throat, ear pain, up until, high-level trauma.
And we just interviewed Leroy Ebron, who was a corrections officer at Rikers Island, and he was talking about kind of the PTSD that would go with what you would experience at Rikers Island with the inmates. And I'm assuming that the same thing holds true of a hospital emergency room.
Yeah, I think it becomes hard to separate sometimes, yourself from the situations that you're taking care of, and trying to put yourself in place of what these folks are going through. I think as a dad of 3 girls, prior to having children, the pediatric realm, was bothersome, but probably didn't bother me as much as when you have your own kids and you say, oh my gosh, what if this was my, 3-year-old that was going through a similar situation? So I do think it's hard to sometimes step back, but we have a job to do. And, we see life and death, and then we need to kind of step out and step up and move on. So you need to kind of come up with your own strategies of how you deal with that. Everyone deals with that a little bit differently. But to be successful and have a long-lasting career there, you need to be able to decompress. And you need to be able to decompress and move on for the next patient who needs your help and care.
So I think it's an unfair question, but I'll ask it anyway. I would not imagine that you get used to seeing people die, especially younger people, but there must be some kind of, mechanism that you use, like you said, to be able to leave that patient and then go to the next one.
Yeah, I mean, I don't think it ever gets easier. And whether the person is 150 or 5 years old, for me, those instances never leave me. But you do have to have a mechanism that allows you to decompress and kind of shut yourself off from that case to be able to move on and care for the rest of the patients that you're, assigned to take care of. It's a ever-moving target in the ER. It's never just one patient at a time, right? A lot of us are managing multiple patients at the same time. So knowing when you need to step out, have a colleague help or assist, those are all the mechanisms I think a lot of us use in order to be successful and able to kind of shut things off for a brief period of time and then, re-engage and move on to the next case.
It's funny you were talking about having 3 daughters and how that changed you. And I remember after I had my children, if I read an article in the newspaper about a child that was, say, for example, a girl, and I have a daughter, and that's about the same age, I immediately just think to myself, what would I do if this was my child? And I can't even imagine what you must go through in the ER when you have those types of things.
Yeah, it completely changes your outlook and your dynamic, and in a way that I never could have imagined, I think, before having kids. And so you always are kind of putting yourself, and empathy obviously is a huge part of this job, and being able to feel what other people are going through makes you successful as a clinician, and being able to connect and have a relationship, even for a short period of time like we do in the ER. I think it's hard sometimes to step out of that. But at the end of the day, I feel like we have a job to do. I have a job to do. And so in order to perform that job, you have to come up with strategies that help you to decompress. And for me, being outside, being physically active are all the things that I do to keep my headspace clean. That allows me, to be successful and have a successful career at this.
I have a friend of mine who was a firefighter in our town, and he responded to a call where a young girl was tragically killed. And he had a daughter that was about the same age. He went to the site of where this happened. He did what he needed to do. He went back and performed his job. And he told me that about 4 weeks after this incident, he just started sobbing in the shower, like it was this thing that was lingering in his head that just came out.
Yeah, and I think that's important because I think when you're amidst a tragic situation or a critical situation, the adrenaline is pumping, right? And firefighters, police officers, medical folks, we all know what we have to do to be successful, right? Or try to be successful in that situation. And so I think a lot of times it never hits you the moment of or the hours after, but I find myself replaying those cases sometimes weeks, even months later. And for us, it sometimes is, what could we have done different? And a lot of times nothing, right? This is just, the way things go, and nothing would have mattered or changed the situation. But there's always something to learn in medicine, right? None of us have all of the answers. So looking back can be helpful. But I think in those cases where you find yourself kind of slipping and it's becoming more of a recurrent issue, that's where we need to be reaching out for help and, destigmatizing the fact that medical people can't be not okay and ask for mental help and mental support. But unfortunately, in this career and in that line of work, we're seeing tragedy almost on a regular daily basis.
And what I do for a living as a personal injury lawyer, I have seen way too much death. And I deal with the parents or the siblings or the, other family members. And I just can't even think. I mean, you must have had situations where, a young person passes and then you have to be the person that tells the parents.
Yeah. And it's never an easy discussion. It's hard not to get emotional in those discussions.
Oh my God.
And it's hard to not feel the pain of that. And for me, showing vulnerability there, I think, goes a long way. As a parent myself, I don't know that I would want someone to be rock wall with no emotion at all telling me that my child just passed away. So having that bond and being not okay to deliver the news, I think goes a long way in showing the families that, we've done what we could do. And unfortunately, the outcome is not positive. And again, even in the best situations, sometimes, unlike the TV shows, we're not saving every single person's life. So we do the best we can do with the circumstances that we're given. But unfortunately, a lot of folks don't survive. And again, I think that connection is important. And I think showing vulnerability and that true empathy that you can connect and feel what this pain will feel like goes a long way to help.
And I think these TV shows really do it a great injustice. I mean, they're TV shows that deal with lawyers, and they're just so nonsensical. And then you watch a show like House, where he figures out every rare thing that goes on, and they send the team of doctors to their house while this person is in a coma to see if there are any things within there. And I'm thinking to myself, where are they coming up with this stuff?
Yeah, I think, it's truly dramatized. And, House is a great show. And, we laugh sometimes, because he just says it what it is, right? And I wish that one day a year we could just let it loose, right? And, there are pieces of the medicine there that I think are important, but nobody's the guy that's getting every single challenging case and has a team of 50 people surrounding them that's, going to the home and here and there and everywhere to help figure things out. So, I think some of these shows do a good job at giving you a little bit of background into the disease of medicine, but it's high drama that doesn't really go on in the hospital setting.
Let's talk about some of the more memorable cases that you've seen in your career in the ER, if you could talk about those.
Yeah, I mean, so, we see crazy stuff. We've seen things that in people's orifices that you could never imagine end up there. When I was thinking about this and somebody was asking me at a party recently, what's the craziest thing that you've seen? And there was myself and one of my colleagues there, and we see a lot of crazy foreign bodies that end up in, rear ends, front ends, vaginas, et cetera. And the stories are always entertaining. It's always 3 a.m. It's always they went to grab the medicine bottle, and the medicine bottle happened to fall just right on the bathroom floor, and the medicine bottle or the medicine bottle cap happened to get stuck there, and now they're here to get this foreign body removed. It's amazing what people come up with as far as
Well, it's funny you say the 3 a.m. story. When I did DUI work, and this was decades ago, everyone that I spoke to that was arrested for DUI had the exact same thing to drink. 2 beers.
2 beers, yeah.
How much did you have to drink? 2 beers. Everyone had 2 beers. And then everyone that comes to see you with these orifice objects are 3 a.m.
3 a.m. Similar story, the boyfriend or the girlfriend convinced them to try this. It's never their own doing by any means of the word. And it's always the same story. And obviously it's highly embarrassing, right? Now you have, the whole emergency room is going to be talking about this, HIPAA or not HIPAA, right? And now you have to, put up with how are we going to remove this thing. So I think those are some of the crazy things that we see. Another really crazy one is we had somebody zip tie their testicles. And as a man, you could imagine, right? I could never imagine how, and let it go on for almost a 24-hour period. When they came in, they were essentially necrotic. So, talk about excruciating pain, right? You could imagine what it's like to get kicked in the groin, right? And now you're sort of self-doing this.
Well, and we all make bad decisions, but I can imagine the last little pull of the zip tie, you must think to yourself, maybe that wasn't the best idea.
Yeah, so, and it's just, we see a lot of, crazy things, and you wonder what goes through people's head to do this crazy
How do you
stuff.
get the zip tie off?
So we wound up actually being able to cut the zip tie. The problem is what's the trauma to this person's, testicles, which essentially had to be removed surgically because there was no blood supply and at that period of time, so...
you make the bad enough decision of putting that zip tie on your testicles, and then you say, well, let me
How
wait
long
24 hours and see if it's going to get any better?
So, yeah, that was probably the craziest one we've had.
What are some other good ones?
I think the other sort of, we see a lot of interesting cases. I think coming out of COVID, we had a lot of interesting cases, and I think COVID was a huge learning experience for us because in the early stages of COVID, we had no real playbook as far as how to go about this illness. And we were seeing a lot of critical ill patients, and I'd say probably every third patient that we were caring for in that first wave of April, May, June of 20, we were putting these people on ventilators. They were going to the ICU with really no care because there wasn't really any directed therapy at that time to help these folks. So those folks stick out of my head because we look at what COVID is now, and it's, kind of a bad upper respiratory infection for most folks. They're generally not ending up as sick as those first wave were. And we do have, obviously, things to offer people that we had nothing to offer them now. So those cases coming out of that stick in my head, because I think that was a turning point in medicine, and I think it was a challenge for us in the ER, because we're not a group that tends to not throw our hands up and say, "Hey, we don't have anything else to offer you, or put you on this machine and hope that you survive." And so for those 3 months, 6 months, where we had a limited therapies, I think it was very hard. I think it was challenging, and I feel for those folks, because a lot of them ended up passing away and not making it.
And alone.
Because
correct. People couldn't come and visit them.
Yep, seeing that loved one on an iPad or through some, wooden door. And, you talk about PTSD, not just for the families, but for the staff involved. To watch somebody have nobody there to lean on at the end of the last hours was tough.
Did you get COVID?
I got COVID twice so far, knock wood, but not during those first wave. We got COVID. Our family got COVID coming back from a vacation in Florida about a year and a half into the pandemic, so to speak, and none of us were really sick. And then we've gotten it a subsequent time, but nothing drastically bad.
And a funny thing for me is, I was going out with somebody who got COVID, and we were together. And I've been around other people that have had COVID, and I have O negative blood. And I'm told that having O blood has an effect upon your ability to contract COVID. But I'll knock wood and say I have never had COVID.
It is. It's a bizarre illness, because the second time we got COVID, one of my 3 daughters got it and the other 2 didn't. So we're all living in the same house. You're not really quarantining in your own house, right? So to your point, how do you explain that we're all around each other and 3 of us have it and 2 of them don't have it? So there is something that I think we just don't fully understand that's completely protective for some people versus others. But
I had a client come into my office years ago who was an immunologist. And I said, "What are some interesting stories?" And she said, "Well, we're doing research right now. There's an area in the former Czech Republic where people did not contract the bubonic plague from, centuries ago." She said, in that same area today, people do not get HIV.
Interesting.
And I said, "What's the explanation for that?" And she said, "There is no explanation."
Yeah, I think there's a lot of medicine that we don't fully understand, and you can't discount. But it is interesting, right? It's interesting how, one area of the world is immune to this horrible disease.
So do you have any patients that you've seen that have had a very profound effect upon you?
So, yeah, I think one of the most profound effects was during that COVID period. I had an elderly lady from a nursing facility whose, family couldn't come, and she was floridly septic from a horrible infection, and near end stage of life with a lot of other chronic medical issues. But we essentially were a family at the end, watching her pass from her horrible illness in the ER. And her family completely locked out. We FaceTimed, as a means to try to get them to be able to have last time with her. But that took a toll on me for a long bit, because nobody should ever be alone, right? And to be in a situation like that, where I can't imagine that it's not uncomfortable, fearful for, whatever your belief in the higher power is, and to have nobody there and these, random healthcare people as your only family, has to be a stress that nobody really should be going through. So that was tough. That was one of the tough ones.
And the thing that you said to me, which really kind of hit home, was, when you tell parents that their child has passed and you're kind of wallowing in their misery and feeling their pain. My mother died many years ago at the Danbury Hospital, and she died as a result of many health challenges that she had. But I remember they called us and they said, she just passed. And there was a nurse at the door, a male nurse, and he said, you can spend up to an hour with your mother. And I said, we won't need an hour, but thank you. And then we said our goodbyes. And then as we were leaving the room, the nurse said to us, "Have a nice day." And I thought to myself, you just left your dead mother, who you've seen dead for the first time in your life. And then he says, "Have a nice day." And I thought, I almost said to him, "How can you tell me how to do that?"
Yeah.
And it's so interesting that people they're just so used to their job that they don't think about it as they're human beings experiencing something for the first time, and it's so traumatic and it's so incredible for them. And I just remember thinking, wow.
Yeah, and I think, that's sort of disturbing, right? I mean, it becomes a routine. At the same token, I think a lot of that, people are uncomfortable having those discussions, regardless of how many times you've had that discussion. It's never easy, right? I think there's always this notion of, is someone going to pass judgment of what we should have done, could have done? So some of that sort of dismissal technique, I think, is people's uncomfortableness in that whole topic of death and dying. But to your point, I mean, there needs to be some connection. I mean, we don't have the longevity that, a physician like Jeff Michaelis has with his primary care patients for 35 years. So in their last hours of care or treatment, that's the least you can give to somebody's family, is my personal take. And I think in order to be successful, that's what you have to do.
We wanted to take a quick break to remind you about our sponsor, findagreatattorney.com. Dealing with the aftermath of an accident or injury can be overwhelming. And the last thing you want to worry about is finding the right lawyer. Findagreatattorney.com simplifies the process by connecting you with one of the top attorneys in your area who specializes in your specific type of case. Whether you've been injured in a car accident, suffered a slip and fall, or experienced medical malpractice, findagreatattorney.com has a network of experienced lawyers ready to help. And remember, their service is completely free, so you can focus on your recovery without worrying about the cost of legal representation. If you or someone you know needs legal assistance, don't hesitate to visit findagreatattorney.com and let them match you with one of the best lawyers in your area for your needs. So obviously you're in a very high stress environment. So how do you deal with that? I mean, you leave the hospital, you go home, and then does your wife say, "Oh, hi, honey, how was your day?" Or do you go into your room, or do you?
Yeah, I mean, I think everybody kind of handles things differently. For me, I'm a very physical activity kind of person, so I love that decompression, to get a workout in and that sort of thing. I'm lucky because my wife's a nurse, so that's where we met, at the hospital. So she lives and kind of breathes the same stuff and kind of gets the same wavelength. So for me, I think I'm lucky because I don't have to explain anything sometimes. She knows, right? And she knows the struggles of what goes on there. And what can transpire day in and day out. And if, and back and forth, if we need 5 minutes, 10 minutes, a half hour to decompress at home, the other person kind of jumps in. So for me, I live in Newtown, so there's some travel time home. So that is a time to put music on and kind of decompress in the car. But then usually when I get home, engage a little bit, get a workout in, and then I'm ready to go and be dad for the rest of the evening.
So for people that don't realize where we are geographically, we're in our studio in Ridgefield, which is less than 10 miles away from the Danbury Hospital. And then less than 10 miles away from the Danbury Hospital in the other direction is Sandy Hook. And Sandy Hook is the place where they had that horrific shooting. Can you talk about what happened in the ER that day? Because that's where people were taken.
Yeah, I mean, I unfortunately, or fortunately, depending on how you look at it, was not working that day. But a lot of my colleagues, obviously, who I've worked with for 25 plus years there were. So obviously that was a horrific day, mass shooting. We had hundreds of people on call and ready to go. Everyone from the ER staff to the surgical staff to the pediatric staff, ready to treat anybody who walked through the door that day. And the unfortunate piece of this is that there really wasn't anybody to treat. There was nobody brought to us who was alive. We had very few cases brought to us. I think a handful, maybe 2 or 3 cases brought to us. And our team was actively involved in their care, but none of them survived. And probably weren't going to survive regardless of what could be done after this horrific massacre at that school. And, those folks are still dealing with a lot of that aftermath. You could imagine what that looks like. I mean, if anyone is aware of, the weapon that was used and what it actually does to physical objects, you could only imagine what it could do to a human body, and especially a small human body. And to have to be one of those folks caring for somebody there, I mean, I can only imagine.
And when you deliver this news, not so much in this situation because of the circumstances, but when you deliver the news to a parent about their child not making it through whatever the situation was, the initial reaction from the parent is, no, that can't be. You must have made a mistake. And then I guess you try to figure out how you could change that to bring the child back. And it's so surreal in how that whole thing unfolds, and how normally during the course of the day you can think rather logically, and logic is completely out the window in a situation like that.
Yeah, I mean, those cases, I think we are good as healthcare folks making sure that we're looking out for the person who's involved in the care of those children in those horrific cases, and having that person step out for an hour, 2 hours, the rest of the shift, whatever it may be, because it is hard. It's hard to get back in a headspace and then actually make decisions, right? And caring for patients is not sort of cookbook, so you have to be able to make decisions. And if your headspace is not there, it's just set up for failure. So I think in those cases, people need to step out, and we fortunately are a big family and cover for each other, so that person can decompress what the time that they need to decompress.
And one of the worst cases I was ever involved in, apart from death cases, was a case where a young woman, I think her first year of college, was involved in a motor vehicle accident and was a quadriplegic. And it's almost like, as a parent, witnessing a living wake, in that your child is alive, but I mean, other than just blinking their eyes or something, it's just...
It is. I mean, life is, ever changing and can be taken away in a second. So, we should all be living our lives to the fullest and the most meaningful way possible, because, what you're doing right now may not be what you're doing 10 minutes from now. And, we see that day in and day out in that career. Where folks, are minding their own business on, I-84, the highway here, going from, Danbury to Newtown, and then, get hit by somebody else, recklessly driving, drunk driving, or, et cetera, and their life's changed. They're, now ending up in a wheelchair. They're ending up now a traumatic brain injury and needing full care. So nothing's a given. So I think, the moral of the story for me is that every day matters, and you got to live for every day, because it could be taken away in a second.
And for someone that does what I do, someone especially that does what you do, that's front and center in your life. So that in the blink of an eye, things could change. And bad enough that they could change for you, but for, your children, for example, or other loved ones that you have, and the senselessness of some of these accidents, which aren't really accidents. I mean, if you consume alcohol where you're intoxicated and you harm somebody, that's not an accident. That's preventable. So there's so many different dynamics that go into something like that.
Yeah, it's interesting. And I think, and some of the data shows, but I think since COVID, I always say the world's like a crazy place now. I think there's no holds barred. We have colleagues and each other, or, verbal abuse, physical abuse by patients, family members. That never used to happen. I couldn't tell you the last time somebody would, you might have a disagreement with a patient over a care plan or an expectation, but to be screaming at a caregiver, another clinician, a nurse, et cetera, to be berating them, to get physical with somebody, that was sort of unheard of. And those things happen a dime a dozen now, and that's sort of disheartening, right? But I think that shows you the world that we live in now. At Dunkin' Donuts yesterday, they're screaming at the person behind. I'm like, this person's trying to help you. Why would you yell at the person who's trying to help you, right? Over a coffee at the end of the day. And I say the same thing for healthcare people. You're screaming at the nurse who's trying to help you. Mm-hmm. It just seems like a disconnect to me. But yeah, the world has come unglued, and I don't know how to get back to that semblance of, let's just treat each other with respect, right? At the end of the day, we don't have to agree. We don't have to go for drinks, but we need to be respectful.
So I see a lot of the inner workings of the medical profession, as do you. So, an easy question to ask, and I'm sure a very difficult response is, are we better off or worse off post-COVID with medical care?
So, I think coming out of COVID and a pandemic, right, I think there's advances in the way we treat, the way we approach some of these novel diseases, medications and treatments that may have been available but are used for something different that are now morphing. We see that things like, vaccine can be escalated and put out, and those things are great. But at the same token, I think what has changed is this expectation of me care, and not about we and the greater good, but about me, and this notion of I want it now. And it's coming right out of COVID when we had closed down a lot of healthcare that was sort of non-essential healthcare. There was significant backlog for a lot of the preventative services. And if somebody can't get in to see their primary care doctor, now they're ending up on our front door. And, we don't turn anybody away. So, and the ER is not the best utilization for non-episodic care, right? So, Jeff is much better at managing high blood pressure than Brian is in a non-acute setting. So that's where the patient belongs, not in my ER, right? Unless they're having an acute issue, which we can obviously manage and then transfer on. So I think there's a lot of things that we're no better off. I think some of the advances are great. Use of technology and telemedicine, I think, that changed the landscape and the way we can do and provide remote care. But,
so do you think telemedicine is a good thing by and large?
I do think telemedicine is a good thing to a degree, right? So I think that, seeing a 95-year-old person with 90 medical problems over telemedicine is probably not a good utilization of the platform. But I think for routine follow-ups, I think for remote areas that don't have some of the specialists, I think that fills the gap. Is it perfect? No. I would much rather prefer person-to-person care. I think that's the way healthcare should be delivered. But I do think it does fill the gap and can enhance the care that we're delivering to the community that we serve.
So let's talk about burnout with doctors, especially ER doctors and doctors in very high-stress areas of practice. That's something that you've been working on for quite some time, isn't it?
Yeah, I do a lot in the clinician wellness space for the network. Me and another physician from Vassar co-lead an initiative. So coming out of COVID, the numbers were about upwards of 60% of physicians were experiencing some degree of burnout.
And what is burnout?
So that's a good question, right? So what is burnout? So burnout really is not just I don't want to wake up and go to work, which is part of it, but it's physical exhaustion, mental exhaustion, and really at the pinnacle of that is where folks are saying, you know what, this doctor thing ain't for me anymore, and I'm looking to do something completely different, or I'm getting out of this specialty and moving into something else, which for some folks is easier than others. And how people experience that is very different. But the person who normally is easy to get along with, is well-liked by the peers now, starts to become angered, starts to act out, becoming more verbal, may not be showing up for shifts like they are on time like they normally would be, may be now having increasing anxiety and sleep issues. And then substance use becomes sort of a problem in this for some people who, use that as a means to kind of cope, which we know is a bad coping mechanism. And it's this sort of sense that you just can't do another day of what you're doing. And most of us spend years training to do what we do. And to get to a point where you're ready to throw that out is sad and disturbing. So I think the successful health networks, of which I feel like we are one of them, has identified this as an issue and is now looking at how do we build strategies and a culture to, one, identify, yes, that's a real issue, and then how do we put up guardrails to decrease that risk of our clinicians that are experiencing burnout already, and then how do we prevent others from entering that path.
So how do you accomplish those objectives?
So I think the 100% best way is fixing the workplace and not the worker. So a lot of the programs on burnout early on focused on the person as the issue. So it's building resiliency in you as the individual so that, the next time there's a Sandy Hook, you'll be better off because you already went through it once. And we know that that isn't helpful to anybody and it's probably harmful. So, doing yoga and meditation and being physically active and all those self-care programs are fantastic and can't be discounted. But that can't be the sole reason to make everybody better. But what's been shown to help, and the data shows helps, is actually changing the culture of the workplace. So for one, saying, hey, we realize this is an issue, and we're going to attack this as an issue. Looking at efficiencies in the way we practice. Utilization of the electronic medical record, right, is at the bane of everybody's existence. So how do we take away some of those tasks and offload some of those administrative tasks that are now physicians, physician assistants, clinicians are now doing, and give those to other folks who can be filling in that void and not necessarily needing the physician to do that. And removing some of those administrative burdens and allowing doctors, PAs, et cetera, to practice medicine, which is what we all want to do. The documentation is great, but we want to take care of patients. So trying to remove some of those barriers and improving efficiency is one strategy that goes a long way to decreasing burnout.
So and we have talked about this as well. There are other professions, high, intense, a lot of anxiety, a lot of stress that go through burnout as well, whether it's lawyers or whether it's doctors or whether it's people that are involved in situations where, there are decisions that have to be made, there are life-altering things that happen. How does the medical profession parallel other businesses and industries that experience a lot of stress and burnout?
I think it's 100% similar. I think, our struggles might be different. The airline pilot is different, has 350 lives right in that plane where I'm responsible for one. So I would make a case that person has a much higher risk than me making a mistake, right? But at the same token, it's how do we put those systems in place that changes the workplace to make the work actually easier and actually allow the airline pilot, allow the physician to do what they need to do with all those barriers. So I think it is a one-to-one situation. The strategies might be different based on the industry, but the process is the same.
Mm-hmm. And I think it's important that you mention the fact that these industries recognize that this is a problem and then they attack that problem. Because I think if you're part of the group of people, the team that's experiencing the burnout, knowing that the company that is representing you is saying, yes, we know this is a problem. Yes, we're going to take care of it. Yes, we need your help, but it's going to get better.
Correct. And I think, we're lucky because we actually have a team of people dedicated to this work, which, shows the clinician pool at large, hey, listen, they're actually, compensating and paying people to actually do this work and drive these initiatives. Mm-hmm. So it means something and it's important.
So let's talk about the medical system right now. And I think we can all agree, whether you're a doctor, a clinician, a lawyer who's involved in this type of work, a patient, or a family member, that the system is broken. And the question becomes, how can we fix that?
Yeah, I think it's a tough question.
Well, let me ask you this question first. What are the biggest flaws in the system currently?
Yeah, so I think my famous quote is that we are all about reactive medicine in this country, right? It's all about having a problem, we fix the problem, and that's how we compensate, or that's how we, compensate providers, right? So the analogy I always use is, you have a heart attack, we put a stent in your heart artery, and that's how that person makes money, right? Or the healthcare system makes money, right, in this sense. But wouldn't it be great if we reversed that and actually compensated folks to keep people healthy, right? Which potentially would drive down overall healthcare costs because we wouldn't need all of those stent procedures if we could help people's lifestyle, manage their high blood pressure, their diabetes, their obesity, and really focus on the preventative pieces of it, which we don't do a great job at, and which we kind of poo-poo, and we don't really compensate the primary care providers in this country who do the bulk of that work, and which is time-consuming, right? And so we're now driving up costs of healthcare because we're focused on all these fancy procedures that maybe we wouldn't need to this degree if we focused on the preventative pieces. The European countries do a fantastic job at that. Their model is not our model. And we don't have to, go down the path of, do we need to have universal health care or not? what they do a great job with is actually recognizing that keeping a population healthy should be the focus. And these other pieces, then you won't need to be spending millions of dollars on.
We did a podcast on the 5 leading causes of death. And when you take accidents out of the equation, the 4 leading causes of death mostly are related to choices that people make, whether it's smoking, drinking, not exercising, excessive eating, and what you're doing to your body. It just, like you said, if you have a heart attack and then you go in and you have a stent put in, you could very well be back in, a year or 2 from now with the exact same problem that you have. So why don't we look at ways that we can get ahead of the wave and say, here are the things that are coming down the road, and you're an ideal candidate for a stroke. You're an ideal candidate for a heart attack. You will probably be dead before you're 60. We need to make some changes.
Yeah. And obviously it's up to the patient to be engaged in that. But, the other piece of that is, if you only have 15 minutes with your primary care doctor, how are they doing a really reasonable job in getting those issues addressed, right? They're not. And that's nothing against them. They're just the system that unfortunately we work in, which I think is what's driving a lot of the primary care market to this direct care model where, their patient panel is shrinking, meaning that they're taking care of less patients, but they're spending more time with patients, right? So instead of a schedule of 20 patients a day, their schedule might be 8 to 10, but those visits are a half hour to an hour. So to your point, are addressing all of those issues, which drive all of those disease processes and drive that top 5 list. So if we could manage that piece, we would be driving down healthcare costs. We'd be driving down the cost of pharmaceuticals and a lot of these medical devices that are extremely costly.
And we were talking about during one of our podcasts how, the medical system is really a business now. And I remember when I was probably 10 years old, growing up in Ridgefield, my mother called the pediatrician, Dr. Sheehan, who was everybody's pediatrician. And they called me Dick growing up. So my mother called the doctor and said, Dick's not feeling well. And the Dr. Sheehan said, we'll bring him into the hospital. She said, I told you he's not feeling well. You're going to have to come to the house. And he said, all right, I'll be there in half an hour. And I'm thinking about this. Dr. Sheen drives to our house to examine me and then writes a prescription for something. And then when was the last time you heard of a doctor going to somebody's house?
Yeah, it's true. There are the house call model kind of has been creeping back, but nothing to the level of that. And, think about the training in those folks too, right? They could do everything. I remember my parents were telling me a story that, my dad had his appendix out by the GP, right? That's unheard of now. We have such specialized care model that there's a person for every problem that, we've lost that. So, those models make sense and I think would do a lot in a system to actually improve things.
And one of the things I would suggest is that wouldn't it be wonderful as a country if we had everyone that goes to medical school goes for free, but you have some period of service that you provide to the community. And it could bring back people like Dr. Sheen. And I remember when one of my children, my daughter Katie, when she was very young, she was playing with like a popcorn kernel and stuck it in her ear. And we couldn't get it out. So I took her in to see Dr. Sheen, and wonderful Dr. Sheen was trying to get it out with this probe. And I said, what happens if you can't get it out with that probe? And he looked at me and he said, we're going to have to put her in the microwave, her head in the microwave and pop it out. And my daughter just looked like this. And then somebody else brought their child to Dr. Sheen and said, Dr. Sheen, my child is always moving around in the high chair. How can I get him to stop? And he said, slap his leg.
Yeah.
Just very practical information. But to have doctors come out of medical school with no debt, and then whatever the financial compensation is to kind of level that out, have them as these community health advocates.
No, I think that's a fantastic point, and I think it would go a long way. And I think most people would not be opposed to that if they're getting, $250,000 potentially of education or whatever it costs now.
Oh, way more than that.
To go to medical school, right? And what you're coming out with. I think that's a model. We need more primary care, right? The focus should be primary care and less on this specialty model, which is what we do now. Everything is about going to see the next person, which obviously we all have a skill set, and you can't discount that people need specialists, but it's become so fractured. And then what's the communication like? I get people in the ER that are on the same medications. They're taking 3 of the same drugs. I mean, because none of their doctors talk or read each other's notes. The EMRs are all different. And so you wonder why they have a problem. Well, because not everybody understands, right? And you gave them this prescription, the cardiologist gave them this prescription, not realizing that they're actually the same drug that you're now taking twice, right? So
a friend of mine's son recently graduated from medical school, and he gets a job as a radiologist. And we're just having a conversation about this. And his first year that he's working as a radiologist, God bless them, he's making $400,000. Like your first job out of school, you're making $400,000. And I'm thinking to myself, I think I know one of the reasons why this system is broken. Or I told you the story that my father, when he was alive, was taken by ambulance to the Danbury Hospital. He's probably 90 years old at the time. He's having chest pain. And they wheel him into the ER, and he's number 40 in the queue. And there are people there that are coughing, they have the flu, their head hurts. And I'm thinking to myself, how are we not triaging these things and managing them better? And I think the answer is because we're just overwhelmed with having so many patients going in to see doctors. And I don't know what the answer is other than I would think free medical school and then having some kind of, community service.
I look at where graduates are going out of medical school, they're not going to primary care, right? I mean, the same thing happens in the PA realm. And the PA realm kind of mirrors what the physicians are doing. Specialty care pays, right? So why would you do primary care? That's a less paying specialty where you're now checking your messages at 10 o'clock at night. You're on call when you could be the radiologist reading from a home, potentially, right? Some of these
making $400,000 right out of school.
Correct.
Or one of the things you might want to think about doing is becoming a concierge doctor where they charge, $3,000, $5,000, $10,000 a year, and then your insurance on top of that. It's a good gig. So as our time is drawing to a close, Brian, I wanted to give you an opportunity to kind of sum everything up and give us your words of wisdom.
Yeah,
there.
I mean, obviously the ER is an ever-changing animal. I think, obviously we are there for acute issues. That's the best utilization for us. We see all comers, which I think is the most. For me, that was my favorite part of the job is that there's no saying no to anybody, regardless of your ability to pay or not pay. But with that notion, I think we need to really look at this system and get this system cleaned up because this is not sustainable. And I look at my kids and say, what's going to be left for them? We're spending way too much money. We have an unhealthy culture in this country in lots of areas, but specifically healthcare, health. And we should do better. We shouldn't be trailing behind a lot of these other developed countries and nations that are doing this really well and spending a lot less money in doing it. So I think it's a wake-up call for us.
Brian, thank you very much.
Thank you.